Good morning, everyone. Uh, so the session is Professor, Professor Manoria, sir, who is an excellent orator, teacher, and legendary cardiologist, who would be speaking on sodium zirconium cyclosilicate. Over to Professor Manoria, sir.
चाय बना सकते हैं?
तुम इसको सेल को रख लो ना वहीं पे।
So for the next 15 minutes, I'll be talking on hyperkalemia, which all of us know is the most dangerous electrolyte imbalance. But now we are going to have new weapons in our armory to fight the devil of hyperkalemia. And sodium zirconium cyclosilicate is very likely to be introduced in India in near future, and that's why we have selected this topic. Now, hyperkalemia is commonly encountered in cardiorenal metabolic practice. Cardiologists, nephrologists, diabetologists are very much concerned about hyperkalemia, as you heard from Dr. Kher. If not timely recognized and aggressively treated, it can even be fatal. Hyperkalemia initially does not produce any symptoms till late, and the diagnosis is usually made either by serial ECGs or serial potassium estimations. There is a rough correlation between the levels of serum potassium and ECG changes. As you can see, if it is 5.5 to 6.5, the T waves become peaked, the PR gets prolonged. If it increases from 6.5 to 8, P waves get lost, QRS gets prolonged, ST segment elevation and ectopic beats and escape rhythm. And if it is more than 8, there's progressive widening of QRS, sine waves, ventricular fibrillation, asystole, and even death. Now, this is a typical electrocardiogram on the basis of which you must suspect hyperkalemia. These are tall peak T waves. They are symmetrical, unlike an ischemic T wave of hyperacute myocardial infarction, which is asymmetrical, and the base is narrow. And you can also see the P waves is not clearly seen, and there's widening of QRS. So with such an ECG, hyperkalemia must be suspected. This is another electrocardiogram. Again, you can see very tall, spiky P waves with a narrow base, and you cannot see the P waves clearly. Sinoventricular conduction persists in hyperkalemia, which means when you give atropine to this patient, despite the P waves being not visible, the heart rate increases. This is because the intra-atrial pathways are suppressed by hyperkalemia and not the sinus node. So the impulse from sinus node travels to the AV node without producing P wave because the intra-atrial pathways are suppressed. Now, this is again another electrocardiogram. Here you can see ST segment elevation, which can mimic Brugada, and the P waves are again absent. And so what is roughly the incidence of hyperkalemia in cardiorenal metabolic practice? In advanced stages of CKD, especially with diabetics and on RASI therapy, 40 to 50%, severe heart failure on MRAs, spinal electron, 40%, hemodialysis, 25%, diabetes over 3 periods, 17%, and resistant hypertension on MRA again, 8 to 17%. Now, if you have hyperkalemia, this is associated with increased risk of cardiovascular events also. And as the CKD progresses, you can see hyperkalemia goes on increasing. It is roughly 57% stage 5. No CKD, hyperkalemia is less. CKD, it is more. Now, what are the adverse effects of hyperkalemia? If you look in terms of all-cause mortality, if you have the triple combo of heart failure, CKD, and diabetes, the increase in all-cause mortality is maximum compared to diabetes alone, HF alone, or CKD. The risk for hospitalization for heart failure is also increased. If you are CKD patient, the risk is increased by 3.8. If you are a heart failure patient, the risk is increased by 2.8. Hyperkalemia also increases MACE, as you can see here, and has some contribution to progression of CKD also. And if you don't treat hyperkalemia till late, this is the terminal electrocardiogram and patient will die of hyperkalemia. One of the common problems which we encountered in our cardiac practice or cardiorenal practice is hyperkalemia when it occurs with the use of RASI and MRAs. What should be the strategy? Now, it's very important to remember that if we down titrate or discontinue RASI or MRAs, this is not an appropriate strategy because RASI decreases CV morbidity and mortality, they slow CKD progression, and if you decrease the dose or discontinue RASI, there's increase in the cardiorenal events. And therefore, the best strategy is try to lower potassium and try to continue RASI and MRAs. And now with new potassium binders, which are going to be available in India soon, like sodium zirconium cyclosilicate, we may be possible to utilize this strategy. And all guidelines recommend that renal dysfunction with hyperkalemia are the major cause of underuse of RAS blockers and MRAs in clinical practice. Now, if you decrease the dose or discontinue RAS therapy, there are adverse effects here. You can see this is the maximum dose. You will have more events if you decrease the dose or totally stop it, whether you are treating CKD, whether you're treating heart failure, diabetes, or total population. If you down titrate RASI again, you can see there is also adverse events in terms of mortality. There's also increased hospitalization for heart failure, 43% increased risk of RASI discontinuation. There's increased heart failure hospitalization, 40% in risk of down titration. There's increase in hospitalization for heart failure. And this shows whether you discontinue RASI or use in submaximal dose, the outcome is bad. So our attempt is to continue RASI as far as possible, treating hyperkalemia by various ways, particularly with new potassium binders like sodium zirconium cyclosilic, which are going to have in future. And if you look at the real world practice, when RASI is stopped, the mean duration of RASI discontinuation has been 1.9 years in heart failure, 2.4 in CKD, which is not appropriate. And 76% of patients were not introduced to MRA during subsequent year. It's also very important that hyperkalemia once occurs in cardiorenal practice. This is a chronic problem. It will occur again and again. And you have to design a long-term strategy. And as you can see, the risk of hyperkalemia increases to about 56% by 6 months once a hyperkalemia occurs. And once it occurs, it starts occurring earlier and earlier. You can see first it is 45 days and later on becomes nearly 70 days. So whether you are treating CKD or whether you're treating heart failure, occurrence of hyperkalemia once, it is likely to recur again and again with shorter interval of time. Only few patients are retested for hyperkalemic episodes, which is not appropriate. Once the patient develops hyperkalemia, you should test repeatedly because it's a recurrent problem. The conventional treatment of hyperkalemia, I think, is known to all of us. We use calcium chloride to antagonize the effects of hyperkalemia on the myocytes. We drive extracellular potassium into the cells by insulin and glucose, soda bicarb, and terbutaline beta agonist, and then remove excess potassium from the body by loop diuretic, as you heard, or by the older resins, which have higher toxicity. Newer potassium binders will be more useful. Or lastly, hemodialysis remains the last option. These are the foods which are rich in potassium you should be aware of. Now, this is a new drug, sodium zirconium cyclosilicate. Is an inorganic crystalline zirconium silicate compound, not a polymer, insoluble and doesn't expand in water, and highly selective for potassium in vitro, sodium with partial protonation. Now, this is the harmonized trial in 258 patients with sodium zirconium cyclosilicate. Comorbidities were CKD, 66%, heart failure, 36%, diabetes, 60%, and RASI use 70%. You can see potassium decreased by 0.2, 0.4, 0.5, 0.7, and 1.1 milliequivalent. And by the end of 2.2 hours, the potassium is normalized. 84% of patients achieve normokalemia at 24 hours and 98% at 48 hours. So this means this drug has a rapid onset of action and is very useful if you have an acute rise of hyperkalemia, unlike Petromar. And it's also a data up to 1 year so that you can use this drug for a long time to minimize hyperkalemia, which is recurrent in the long run. This is the realized trial which tried to study patients of heart failure who are already on an MRA and have developed hyperkalemia, or heart failure patients who are likely to develop hyperkalemia, and the mineralocorticoids were started, and when hyperkalemia occurs, this drug was used, and you can see larger number of patients were able to achieve the drugs like spironolactone when the sodium zirconium cyclosiliate was used. This is the data from real world optimized trial, which again shows that you can use RASI when you are using this drug in 70% on maintenance dose, as you can see here, and 13% or 9% you can increase the dose. Decreasing RASI therapy was required only in a very small number of patients. Patients on sodium zirconium cyclosiliate has double the odds of maintaining RASI therapy versus patients who are not a potassium binder. So if you use potassium binders, you are able to continue RASI 2.5 times higher. And this is an overview of the various potassium binders. These are the old potassium binders, sodium polystyrene sulfate, or the CPS. The problem with this is they are very toxic. They can produce intestinal necrosis. The dose is 15 milligram 4 times a day. And Petromar has the problem that 4 to 7 hours is the onset of action, is non-specific cation bonding in exchange with calcium. The dose is 8.5 milligram once daily, and hypomagnesemia and GI side breaks may be problem. With sodium zirconium, you can see the onset is very rapid, 1 hour, 10 milligram 3 times a day for 72 hours, and 5 milligram or 10 milligram later on. And it also acts on the colon, and hyperkalemia and edema-related edema occurs because of retention of sodium. This is generally well-tolerated drug. You can see side effects occasionally. You can have edema due to sodium retention. You can use diuretics. Hypokalemia occurs in small number of patients. The drug is not absorbed from the gut, so drug interactions are rare or not there. And this drug can be transiently increase gastric region, should be administered at least 2 hours before or 2 hours after the oral medication, with clinically meaningful gastric pH dependent bioavailability. All guidelines have recommended sodium zirconium cyclosilicate for treatment of hyperkalemia and try to maintain the RASI dose, whether it is KITGO guidelines, whether the ESC guidelines, or whether it is other guidelines. So in summary, cardiorenal patients, hyperkalemia is an ongoing threat and is associated with increased cost, mortality, and hospitalization. Guidelines recommended RASI for patients with CKD and heart failure. In the event of hyperkalemia, this should be treated with potassium binder to enable the patient to remain on optimal RASI therapy. Discontinuing RASI is going to increase the cardiovascular and the renal events. So sodium zirconium cyclate, the advantage are is produces a rapid onset of action, so rapid reduction in potassium within an hour. It can be used for a long time, reduces medical cost and hospitalization, and generally well tolerated. Over 7,000 patients across the clinical trials, and nearly 9 out of 10 patients continue to use RASI with sodium zirconium cyclosiliate.
Thank you, Professor Manoria, for such an enriching session. And 2 points were very important that struck my mind, that in majority of the patients who develop hyperkalemia, we have seen the doctors, they reduce the dose of RASI. So it's very important to give RASI at an optimal dose rather than giving them at an suboptimal dose and bind a potassium binder. So now the session is open for questions. Any questions from the audience?
Sir, in the last speaker was speaking about Finerenone, and we were worried about hyperkalemia along with ACE inhibitors and other RAS blockers. Can this be used on a longer term or in that scenario, sir? Just to be on safeguard for hyperkalemia.
I've already shown the data for 1 year, but it can be used for a longer time. The long-term data beyond 1 year is not available because hyperkalemia is a recurrent event. If you are doing cardiorenal practice, this is heart failure or CKD, it keeps on coming and going. So you have to have on a maintenance therapy.
How
Thank you, sir.
rapidly it reduces potassium?
Hello?
How
Yes.
rapidly it reduces
Onset of
potassium?
action, I said, is 1 hour. I've shown you the harmonized
Yeah,
trial.
onset you have
Starts acting 1 hour, and within 24 to 48 hours, most of the patients will achieve normokalemic levels.
Dr. Manoria, sir, what is the absolute level of potassium? Is it 5.5? Is it 6? When you would consider?
See, after 5 is the usual cutoff point. Some people take 5.5, but you should not wait for the potassium to escalate further because it's a dangerous electrolyte. After 5.5, you have to be very...
So amongst the 4 drugs which are used to treat heart failure, RAS blockers, ARNI, SGLT2 inhibitors, and MRAs, which drug produces maximum hyperkalemia?
Hello?
Yeah. So amongst the drugs that are 4 drugs that are used to treat heart failure, that is RAS blockers, ARNI, SGLT2 inhibitors, and MRAs, which one produces maximum hyperkalemia?
See, maximum hyperkalemia is caused by RAS blocker and ARNI. SGLT2 inhibitors does not produce hyperkalemia. It may decrease potassium level. MRAs also produce hyperkalemia, and Finerenone, the hyperkalemia is much less compared to a RAS blocker.
Is it available in India?
Going to be shortly available, going to be launched by AstraZeneca in near future, very shortly.
Sir, in severe hyperkalemia, you have to start all the things together. This, along with calcium gluconate, along with the insulin, bicarb drip, and all that. Or is it alone sufficient?
Calcium gluconate is mandatory because it decreases, it minimizes the cardiac events. It does not decrease potassium levels. So
Yes.
calcium has no role in decreases potassium levels. Drugs which can decrease potassium levels, I already pointed out, you can use glucose insulin or you can use resins. These beta agonists are usually not used. And this would be a wonderful drug when it is available.
Thank you.
Entity called pseudohyperkalemia. What do you mean by that?
Pseudohyperkalemia occurs when your blood cells are hemolyzed. The RBC may be hemolyzed because your needle was very small, you have produced vigorous shaking, or the blood has been stored for a long time before you have estimated, or in patient with thrombocytosis, some of the platelet may release potassium, or in patients with leukemia, some of the WBC may release potassium, but these patients will not have any ECG features or any other features. So if there's suspicion of pseudohyperkalemia, you have to repeat it.
When we are talking of hyperkalemia, there is also an inverse relation with sodium because we generate electrolytes. So sodium also levels low, we get hyponatremia. So one should also look into that factor along with hyperkalemia.
See, we always look at all the electrolytes. It's not that if somebody is having magnesium is also very important, particularly if the hypokalemia. Hypomagnesium is very important for cardiac arrhythmia. Some of these patients may get even hypokalemia. So we look at the other. It's not that we focus our vision only. And this sodium zirconium citrate, there's sodium retention also. So you have to focus on all the electrolytes. So I
Thank
think
you, sir.
with this, we conclude this. Dr.